I'm going to talk a bit about aEEG because that is what we will display for you while we record the EEG. So the EEG is set up with all 11 channels and the video, but for displaying during the time of the recording, you see the aEEG, which you will be able to use for the management of the babies. So the question is always, how many electrodes do we use? As you could see, we have that you could either use for an aEEG 3 electrodes, or some people use really lots of electrodes to get lots of information in high density EEG. And obviously we will not do this, but we can get far more information if you use more than aEEG and with a two-channel or one-channel aEEG. aEEG has been developed some 40 years ago, initially in the UK, in London, as a tool for intensive care for adults by Maynard and Pamela Pryor in London in the 60s. And then that was picked up. Actually, aEEG is not used much in adult intensive care anymore, or maybe it's coming up again a bit. But Linda de Vries and Lena Westers-Hellström have picked up the aEEG as a tool to use on the neonatal unit. And it's increasingly used worldwide to monitor brain function. There are lots of different monitors available, and the only thing which is important to remember is that all of these tools use a slightly different paradigm to derive this signal. So what you can see here is that what they display is slightly different. So you need to get used to the aEEG you are using, because they all display the signal slightly different. But basically, how do we get, what's the difference between a full or a 10-channel EEG where each of this is 1 second, to a 6 hours aEEG in the same page? How do we get from here to here? Because obviously it's the same, you record the EEG activity and display the aEEG. So this is what happens. You have an aEEG, a normal EEG, and then this will be, the signal will get filtered with an asymmetric filter, and then amplitude compressed in a semi-logarithmic function, then rectified, time compressed via downsampling, and then time compressed again for aEEG signal. So from here to here. You can imagine how much information you lose, but it's much easier to look at this data. Which channels do we use? So this is a full EEG for an older child, and aEEG could be either just one channel from P3 to P4. This is what used to be used when aEEG was initially was introduced into the neonatal unit. Or you can use 2 channels, which is much more common now. So you record over the left and the right hemisphere, either C3 to P3, or some people do C3 to F3, and on the right as well. We in Persist will use this, in Prevent will use this montage, which is the best to pick up seizures in the neonatal period. Most seizures occur over the central parietal and posterior region, so you should be able to pick up seizures the best. And then how do we set the margins? So how do we define normality and abnormality? So this is an aEEG in a normal term baby, and the way you set the margin is you look where it becomes dense, and then you go somewhere slightly above it. So roughly here for the upper margin and roughly here for the lower margin. So in this baby, the upper margin is well above 10 and just up below 25. And the lower margin is above 5 all the time. And what you can see actually here in this term baby is that nice sleep-wake cycling. So this is during active sleep and wakefulness. When the EEG activity is low, mixed activities, low amplitude activities, and in quiet sleep where you have tracé alternant, where you have high amplitude activity and lower amplitude activity, giving you a wide band. So the higher amplitude activity gives you the upper margin, and the more suppressed periods give you the lower margin. And so these little balls, these little bubbles here, are the tracé alternant, the sleep-wake cycling. This is how the aEEG develops over time. So in a premature baby, you would have a discontinuous pattern with a much higher margin. So you have a lower, the lower margin is much smaller and the higher margin is higher. So in a 32-weeker, you have around 25 and below 5, and this then changes gradually to the term pattern. And here you can see how the upper margin, line is the upper margin, how the upper margin develops in active sleep over the different gestational ages and in quiet sleep, and this is how the lower margin develops. This is not so important for the PREVENT study because we only look at term babies anyway. And then this here shows you the classification, what is normal. So we talked about this is normal term baby. In a baby at term with continuous EEG activity, you have this pattern here, which is always normal at term babies. And then you have a pattern which is called discontinuous pattern, where the lower margin is around 5 and the upper margin is above 10, even above 25 here. This is normal in preterm babies, but abnormal in term babies. So in term babies, you always want a continuous activity in the EEG, and if it's discontinuous, then this is abnormal, probably due to a hypoxic ischemic encephalopathy. And then you have a term which is called burst suppression pattern, which is this, and so you can see a burst and suppression. And this is what we call burst suppression in the aEEG. This is not necessarily the same in the EEG, because in aEEG, to call something burst suppression pattern, you also want epileptiform activity, abnormal epileptiform activity in the EEG pattern, which is not necessarily here. You can't see whether something contains epileptiform activity or not. So this is not the same as an EEG burst suppression pattern that we saw in the baby earlier. And actually, if you remember the pattern we saw on the aEEG in the baby earlier today, this looked more like this and not like this. So burst suppression pattern, the term, unfortunately, in aEEG means something different in term babies than in aEEG than it means in EEG. So you just have to remember the context you're using it. And then you have low voltage, which is very low, abnormal at any age, or flat isoelectric. Again, these little peaks in isoelectric are muscle artifact due to ECG or handling. This one? This is, so if you have, for example, a preterm baby who has a discontinuous activity, then you have flatter periods, which means you have a lower, the lower margin drops down because you have flat periods, and you have bursts, higher bursts, which gives you a higher upper margin. Basically, what the aEEG shows you is the difference in amplitudes you get. Whereas if the EEG activity is of low amplitude but continuous, then you have this pattern. Whereas if you have a lower amplitude, a flat periods, then it becomes here, and this is due to the higher amplitude bursts. So I'll show you some examples. So again, at term, you have this pattern of a smaller bandwidth, but the bandwidth varies with a smaller one and then a wider one. So you get those little balls, quiet sleep, wakefulness, and active sleep. The lower margin is always above 5, unless sometimes it drops a tiny bit down, but it's above 5 here. In this one, it's always above 5. And the upper margin is above 10 or above 25 even. So here, and then it goes up here. 25 is in quiet sleep. Normal pattern at term. And a discontinuous pattern, which is a normal pattern in preterm babies, you have the lower margin is below 5 here, but the upper margin is above 10. So as I said, it's normal in preterm babies, but moderately abnormal at term. So it's not a very abnormal pattern, but it's moderately abnormal pattern, which you can see in HIE grade 2 or something, sometimes due to if you give a baby high dose midazolam or morphine. So if you look at this here, this is a term baby, no sleep-wake cycling, and then here something happened. So it goes from a continuous pattern to a discontinuous pattern. And this is why, because the baby was given high dose midazolam. And then burst suppression pattern. There are 2 types of burst suppression patterns. So the lower margin is well below 5. By definition, it's below 5, but really it's nearly 0. And the upper margin is below 10. Again, you look at the bit where it's really dense. So here it's below 10, and here as well. There's no sleep-wake cycling, and there may be there are bursts of higher amplitude spikes. And this is severely abnormal. This is, for example, in HIE grade 3. There are 2 types of burst suppression pattern, the dense burst suppression pattern and the sparse burst suppression pattern. In sparse, there are less of the spikes, so the spikes become even less dense. Again, lower margin is below 10, upper margin is below 10, and it's always abnormal, it's severely abnormal at term or at any age. And then you have severely suppressed EEG activity, where the lower margin is officially below 5, but really it's around 0. And the upper margin is also below 5. Again, severely abnormal at any age. There may be some smaller spikes going up, but that's artifact. And here in this baby, you can see it's low voltage, severe suppression, and then seizures going up. But I'll talk about seizures in a minute. And then the flat trace is more or less the same as the low voltage, but even flatter. So really 0 and then well below 5 for the upper margin too. All these spikes are due to artifact, ECG, or handling. And this is just sort of a summary of the definitions. This classification is the classification by Linda de Vries and Lena Wester-Sellström. There's a different definition which was used for the Toby trial, which is a bit more simplified and less. We are going to use this classification. So aEEG is very useful in evaluating the background activity in aEEG, in HIE. So you have normal discontinuous burst suppression and complete very low amplitude. And the best time is the first to the third day. If you have, you can use this, the aEEG background activity, to help you stage the degree of the HIE, and that will also help you indicate with the prognosis. There are a couple of those papers really show how well the aEEG correlates to prognosis. And finally, seizures. So this is how you will use aEEG. A seizure is diagnosed by a sudden rise of the aEEG band and a narrowing of the trace. So here it comes up, but it also becomes more narrow. Or sometimes you only see a sudden narrowing of the band, like here. It just becomes narrower. So there's no peak going up, like here. It just, inside you see a little margin. It can be very difficult to see if you have a patient in burst suppression pattern, and also status epilepticus can be difficult to diagnose if it's continuous status epilepticus. But here, in this patient, for example, this is a typical aEEG pattern diagnosing status epilepticus, where you have frequent repetitive seizures. So here are a few examples. You look, what is the aEEG showing? What's the background activity here? Yeah. So the lower margin is below 5, the upper margin is above 10, so between 10 and 25. And then here you have status. So you have a sudden onset of status epilepticus, and this is confirmed here by the EEG. So in principle, longer seizures and high amplitude seizures are very easy to detect on aEEG. Here's another example. So what's the background activity again? Discontinuous. And then here you have seizures. Again here, this period is status. So here you have single seizures, and then you have a period of status epilepticus, and here possibly phenobarbital was given a short period where the baby was better, and then the status reappeared. So you have an evolution to status. Again, the aEEG confirms that you have high amplitude discharges. Okay, so here, background activity is discontinuous. Anybody can see any seizures? This is artifact. This goes hard to, it's too high up, so you can identify this as artifact because it's too much. So if we then use the EEG, just anywhere here, you can see that this baby is having seizures. Low amplitude seizures cannot be detected on aEEG because there's no difference in the amplitude. So if you look here, you can see the seizure pattern, which it doesn't show up on here. So it's just important, if you do use the aEEG, to remember that some seizures will be missed. About 20 to 30% of seizures will be missed on aEEG if they are low amplitude, but also if they're shorter. Another problem is here. So here you have the aEEG here. Background activity is discontinuous, and here seizures. Yeah, everybody would be happy to call this a seizure. Sudden seizure. So if you look at the EEG at that time, there's no seizure. What you can see here is the ECG, and you can see there's a very marked high amplitude ECG artifact. And basically what the baby did during this time was lift the arm with the wrist to the electrode, and the electrode was picking up the pulse. And so you have a marked artifact during the time the child had his hand up to the electrode, and as soon as it was gone again, the artifact was gone. So you have something which looks like a seizure, but it's not. aEEG can also have false positive, and you just have to remember that. And this shows how important the raw channels. So for the PREVENT study, we'll give you the aEEG, but also 2 raw channels, and that you would be able to see whether an electrode had become loose, or whether there's an artifact, or whether there's actually seizure activity. And another one, this is a very old aEEG. So it's again a discontinuous pattern, and you have a discontinuous background activity at one point, and another point you have a low amplitude EEG. This is something you can't pick up. Short seizures, low amplitude seizures, you cannot pick up. There's been recently a systematic review looking at the value of aEEG. The problem is there are lots of studies comparing aEEG to EEG, but most of these studies, the methodology is not very consistent, and so this systematic reviews concludes that aEEG, there's not enough evidence to prove that aEEG is sufficient for the diagnosis of seizures if used by its own. I think with raw channels it is relatively good, but obviously not the same as if you use full EEG. Full EEG is the gold standard, but next comes aEEG with 2 raw channels. And you have increased seizure detection if you use centrotemporal or centroparietal regions, if you also have raw channels display, if there's higher frequency of seizures, longer duration of seizures, and high amplitude of seizures. So finally, I'll just 3-4 minutes, a few more examples. So what is the background pattern? Do you think it's a term or preterm baby? Term baby, possibly yes. Any sleep-wake cycling? No. Seizures? Yes. And artifacts? A tiny bit. I mean, you can see those little bits, but it's relatively good. So, yes. So it's a baby who had a congenital heart disorder, postoperatively with long seizures that you can see here. So what is the background activity here? Very good, excellent. This is a baby in status. And here, what happened here? So something must have happened. The seizures disappeared briefly. So the baby was treated with phenobarbital during this time, but it only worked for a short period, and then it went back into status. Status epilepticus can be tricky. I mean, this could also be artifact. This could be electrodes being loose or the baby moving. You need to correlate this with a raw EEG. So here, continuous, but no sleep-wake cycling. So in a term baby, this would be slightly abnormal because there's no sleep-wake cycling. Any seizures? No, no seizures, but there are seizures. Again, they are too low amplitude to be picked up from the aEEG. And finally, the background activity. So here, this is below 5. So if we look at this, burst suppression pattern properly. It's below 5. Well, actually, no, discontinuous. It's above 20, above 10. But you have frequent seizures. So here, and then the baby was treated again with phenobarbital, and then the seizures came back. And this was a baby with intraventricular hemorrhage with frequent seizures.